Good evening, Endo Summit Live, and we're here in our second webinar tonight to talk about GLP-1s and pelvic pain with none other than our physical therapist, Dr. Amanda Olson. Amanda, it is so nice to see you. Can you go ahead and introduce yourself?
Sure, it is so good to see you as well. I'm Amanda Olson. I've been a pelvic health physical therapist for 17 years now, quite some time. And I'm also a person living with endometriosis, and I have a deep heart for helping people manage all of the different issues. I created some tools to help with that with my team at Intimate Rose. We have pelvic wands and dilators, and then I do a lot of educating too. And tonight I was asked to come on and talk about GLP-1s, which is a topic that has gotten a lot of attention lately. And truly, when I see people that I respect very much and hear my patients responding really well to something, it always takes my attention. And that's what's happened here. And I also heard some pretty unkind things being said by other providers about GLP-1s. And so I wanted to help provide some solid education about what they actually are and their role and the data behind them, and then how we help mitigate some of the side effects and keep people active and feeling great.
Yes, so first of all, our most requested question is what about GLP-1? On when you register for the webinars, you're able to submit a question this year. We're very fancy. And the most requested repeated question is what about microdose of GLP-1s for endometriosis? So we had to start somewhere. I wanted to disclose, I went on, now I had PCOS my whole life. So I went on, also, Dr. Gargiulo, don't feel that you have to stay. You can stay if you want, but it's very late where you are in Italy. So it's up to you. Don't feel obligated. Good night. Yes, good night. We love you. See you soon. Okay, so I started a GLP-1 in on Christmas Eve one year, December of 2024. And I'm gonna say, so like you start at a low dose, you start at like 2.5. And by Christmas morning, I no longer had any bladder dysfunction, right? This is why I wanted to share my story because I had done everything for weight loss when I hit menopause. I definitely became metabolic syndrome because I had a history of PCOS, okay? But I didn't expect all the other things. So first, away went all my bladder issues. In fact, I think this is one of the first webinar seasons I'm actually sitting here like drinking water during the webinar because I'm not worried about having to get up and go to the bathroom. I also have a spine defect. All of that pain went away as well. Now, I don't particularly believe that that's only because of weight loss, but because that's a very nerve-related pain. And then the other thing is, when I went on the GLP-1, it took a couple months, but all of a sudden my POTS actually got worse, right? Because it normalized my insulin response, but then I had to do a little work to normalize the cardiac response, right? So one of the things that the GLP-1 sort of like uncovered is that I have to do a certain form of exercise to move in the morning to get all the, or my heart rate goes sky high if I don't. So because I got to move, with POTS, you're not always so great at moving all your venous fluid around, and I got to make sure that that gets done. But it's not, it's about like there's no swelling in my joints, although there is now because the endo summit, but that's only because it's stressful. But swelling in my joints is gone. I back pain is gone, bladder dysfunction is gone, sex drive has returned. It's about a
Oh,
lot more than weight loss. And I think those of you that are looking at trying it, here's why we did the presentation tonight. Yeah. So now take it away.
take it away. Let's talk
Take
about
it
the, but I
away,
mean,
Amanda.
I hope everyone heard all of those different things because that's a lot of different systems, genital urinary, sexual function, psychosocial function, changes in
Well,
cardiac function.
I also think the first summit we ran, well, also, Dr. Bradali lost 70 pounds on a GLP-1 to normalize his numbers as well. But I think the first summit we ran, once I was on it, we realized that it also has a psychosocial impact because it's the first summit. Like he and I didn't like go into another room and scream at each other where everybody could hear us screaming anyway. So because it does mellow you out. And then of course, I combine it with other meds, but it does mellow you out somehow. And then it also improved sleep,
Mhm.
like big time, which in menopause is a big one. And also, for me, who tried everything under the sun to lower my A1C. Like I was keto, I mean, I'm disciplined. I'm in medicine. I know all the good things. Like we didn't eat out, we didn't this, we didn't, right. My A1C was 5.7. I was wearing a monitor. I was like making sure and it was never coming down. In fact, it was so high after exercise. I couldn't eat sometimes till 3 o'clock. So for the last year, 5.0. Like you don't, those of you that are in medicine understand how big that drop really is. So like that's about long-term health. That's not about weight loss, I don't feel. So that's why we're
Absolutely.
here tonight to present, to start this. Now we have a lot of programming because we have been booking speakers on this for the years to come, but this is the start of really this conversation. So go ahead.
Absolutely. Well, I've got a little deck here. And just want to reiterate, I'm a physical therapist, so I'm a non prescribing provider. So I'm coming at this sort of as the quarterback between the patients that are in pain and the other medical management team, of course. And then we are here always in the patient's canoe to help support them. But we are talking about GLP-1s. Um, as I mentioned when we first jumped on, that it's been getting a lot of attention in various ways lately. Something that particularly caught my attention, Serena Williams, inarguably the greatest women's tennis player. We love Billie Jean King too, but Serena, dominant in her sport. She
Greatest
has
female
been
athlete.
what? Yeah, yeah.
Greatest
Well,
female
Simone.
athlete of all time, I feel like, yeah.
Simone too. They're both amazing. But yes, she's incredible and she's extremely active and she knows how to train and all of those things. And she has been transparent with her use of GLP-1s. To help her in the postpartum period as well. And then Chrissy Teigen, former supermodel and now cook extraordinaire. This one really got me, and I do apologize for any triggers here, but she had a loss during her pregnancy, and she started Ozempic after that loss because she said, she came straight out of it. She had a body that didn't feel like it was hers and nothing to celebrate. So she started it then, and she's been a supporter for people that are making this choice and going down this new medical path. So, what is a GLP-1? It is a glucagon-like peptide. It is a hormone that's secreted usually from the intestines. It's from gut endocrine cells in a response to food ingestion. So we eat, and then this hormone gets released. The pancreas stimulates insulin and suppresses glucagon, and the stomach slows down a little bit. And then we have a signal that goes to our brain that says, we're full. Go ahead and stop eating now. And all of this is part of this process that's in place. And in some events, for various reasons, the brain cannot get the information about feeling full. There can be disruption in the release from our body, from the intestines in some cases. And so a pharmacological G1 receptor is the activation reduced glucagon secretion. So that raises blood glucose and gastric emptying. And it led to the development of these new therapies, initially for the treatment of type 2 diabetes. So that's where the journey began. So now we have this new type of medication, and they were FDA approved for type 2 diabetes as the primary use initially to help lower blood glucose levels. It increased the insulin and decreased glucagon and improved the glucose control overall. And then it was looked at and heavily studied for chronic weight management and obesity. So several of the GLP-1s are approved for weight management. We're going to talk about some of the other drug classes as well. But it assists in weight loss via decreasing the appetite. And so it increases the sense of being full. And then it slows the gastric emptying. That's where we're going to have some advisory around plenty of water intake and getting plenty of body movements and having good toileting posture. And I'll go over that here in a little bit. But because of that slower gastric emptying process, you're feeling full longer and you're ingesting less. We want to make sure that you don't then experience constipation. And then the cardiovascular benefits. There's evidence that these GLP-1 RAs reduce the risk of major cardiovascular events, cardiovascular mortality, and stroke. That should be getting all of our attention. That's a big deal. And then for renal outcomes, some studies are showing benefit on kidney outcomes, especially in people with type 2 diabetes. So they work centrally on the hypothalamus, so on the brain and the brainstem, and at the reward centers to stimulate glucose-dependent insulin secretion, and it delays that stomach emptying, as I touched on previously, and it increases satiety, which is the feeling of being full. One of the things that really stood out to me was my patient reports that it calmed the brain chatter. And the food noise that was like, am I hungry? I feel hungry. I want to eat that thing. That thing's in my pantry. I want to eat it. And so some of the decision making around food became more clear about what they really do want to eat. And are they truly hungry? And I think that for a lot of them, they felt less anxious overall. So, that's pretty profound as well. There's not a lot of medications that are acting on a certain system or a certain hormone that are helping people to come to truly understand the relationship with food as well. And then here's another biggie. And I think this is where a lot of different diagnoses are seeing secondary effects. And I think this is where the endometriosis population is probably experiencing this reduction, and it's associated with reduction in inflammation and blood pressure. So at the end of the day, we are getting all of these changes happening, and then also a reduction in inflammation. I've heard other patients report like they're not seeing me for their knee, right? They're seeing me for their pelvis, but they're saying, oh, my knee feels better. I used to have knee pain every day, and now my knee is not bothering me. And isn't that interesting? So here is an infographic showing the effects of the GLP-1. So effects on the type 2 diabetes, type symptoms of the HbA1c, decreased body weight. Some of the cardiac functions are decreasing the risk of stroke and myocardial infarction, that's a heart attack, go down. But there can be side effects. So some of those side effects include some feelings of nausea, in some cases vomiting, constipation. We do see a slowing of the intestines. For some people, diarrhea, abdominal discomfort, fatigue, and in rare cases, gallbladder disease and acute kidney injury. And this is where medical providers are monitoring these people that are starting these medications quite closely and drawing labs and keeping a good eye on it. And different people experience different degrees. I have patients that have had really none of the side effects, and some patients that were quite constipated or feeling nauseous. And that is where looking at nutrition and body movements can be really helpful too. So some of the common GLP-1 medications include Ozempic, Wegovy, Rybelsus. And then there's liraglutides, and you can see those drug names listed there. And then dulaglutides, including Trulicity. That one gets quite a bit of publicity. And then the xenotides here. So different types. And then there came about these tirzepatides. And I think that these tirzepatides are agreeing with a lot of people as well. So they were the first dual agonists to be approved for the treatment of obesity. So straightforward, whereas the original class of GLP-1s was officially first approved for type 2 diabetes. This was the first one to be approved for the treatment of obesity, and it features the GLP-1 and a GIPRA tirzepatide. And it's similar to the GLP-1 prescriptions that was initially approved for the type 2 diabetes and more recently for obesity. But in the tirzepatide, it's a dual receptor agonist, so it mimics two hormones, the glucagon-like peptide, which we talked about in the first class, and then glucose-dependent insulinotropic polypeptide. And this dual action gives it a more potent effect on both blood sugar control and weight reduction than just the GLP-1s alone. And it provides activation to further enhance insulin release and fat metabolism. And it may provide greater weight loss and glycemic control compared to just the GLP-1. So you're getting two actions there. The drug names of these are Mounjaro and Zepbound for chronic weight management. When we look at these further too, there's different physician types referring to the tirzepatide class for other medical conditions like sleep apnea. But the guidelines for the medical weight loss are multiple guidelines for the treatment of obesity, recommend the use of medications, and that they should be considered for people with a body mass index above 30. And more than one weight-related comorbidity. So that could be the diabetes, that could be any cardiovascular risks or stroke risks that they may also be living with. And the patients can take the medications for weight loss if they meet the BMI requirements, even if they don't have the blood sugar insulin-related issues. So here is another list of weight-related comorbidities. It does include type 2 diabetes, hypertension, high blood pressure, dyslipidemia, obstructive sleep apnea, and cardiovascular disease, prediabetes, and non-alcoholic fatty liver disease, and also osteoarthritis. So they're noting there that can be a mechanical complication related to excess weight, but also from a physical therapy standpoint, part of being a person. We are all using our joints all the time, and we can all find ourselves living with osteoarthritis for one reason or another. So another infographic here showing how that GLP-1 acts. It helps the kidneys with sodium excretion. It helps the cardiovascular system with increased endothelial function, decreased arterial stiffness, and decreased inflammation. All of that's helpful to reduce the risk of stroke and heart attack that we just talked about. And then improving myocardial contractility, so making that heart more responsive, glucose intake down and ischemic preconditioning up, and then appetite down and satiety, that feeling of fullness going up, insulin levels and increased glucagon levels decrease. So here's a summary of the evidence. I won't go into too much depth with that here, but there's a series of studies that we're looking at glycemic control, weight loss, cardiovascular risk reduction, and kidney protection and effective body mass index through the Journal of the American Medical Association. And it just goes over a little bit of the evidence there. Okay, so looking at management across the healthcare team and who's going to help you with all of these. So in pelvic physical therapy, as I mentioned, we are very interested in helping people mitigate constipation and also being there on the pelvic function side of things. And that could speak to the sexual function, or it could speak to the bowel and bladder's functions. And then, of course, pelvic pain, which is one of the most predominant symptoms of endometriosis. So for delayed gastric emptying, it may increase their aspiration risk in a perioperative or sedation setting. So those physicians are being mindful in that particular setting. They can use a gradual dose escalation to mitigate those symptoms. They should also look to prolong the titration period or avoid dose increases until those side effects subside. And if side effects appear when transitioning to a higher dose, the recommendation is currently to revert to the previous dose and then gradually increase it. So low and slow and steady as she goes. From a nutrition standpoint, Nutritional recommendations are still to be observing a healthy diet and moving your body. So this an acronym MEAL is maintain muscle. So they're recommending 20 to 30 grams of protein. Pick your type. You can find it in beans, yogurt, poultry, fish, protein shakes if they are experiencing a severe reduction in appetite. And then energy balance. So providing yourself with an easy flow of energy with easy to digest snacks like oatmeal, nuts, fruits, yogurt, using healthy fats when you're cooking. Avocado oil is a favorite of mine. And then mitigating or avoiding, as the A is here, GLP-1 side effects. So for constipation, increasing fiber, staying hydrated. So that's going to look like carrying a water bottle, keeping it with you. For nausea, the recommendation is to avoid fried foods and eating whole grains and to try ginger. There's little ginger chews that you can buy, and they are quite good. And that can be something easy to store in your bag or in your desk to nibble on if you're feeling nauseous. And then liquid for hydration needs. So 8 to 12 cups of water per day or eating hydrating foods. Cucumbers and melons are kind of a nice one if they're in season. And then for physical activity, while taking GLP-1s, the recommendation remains for aerobic exercise 150 minutes per week. It could be whatever brings you joy from my perspective, but brisk walking, Zumba, whatever it is that you like. And then strength training as well. So 30 minutes 2 to 3 times per week using weights and resistance bands. So ensuring that you're getting challenged to the muscles. For additional risk management, for those that are at hypoglycemia risk, especially when they're used in combination with insulin or insulin medications, they need to be closely monitored by their prescribing physician and probably their primary care physician as well. But generally speaking, GLP-1 monotherapy has a low hypoglycemic risk. So these medications are glucose dependent and they only stimulate the pancreas to release more when blood glucose levels are already high. So if you're already doing a good job, your body's regulating that well, the risk remains relatively low. The injection site reactions could occur, and sometimes there can be some antibody formations for certain agents at the injection site. And then muscle mass changes. This is, it speaks to the importance of maintaining physical activity because these medications can reduce the appetite and caloric intake, and there's a theoretical risk of lean mass loss if the diet and exercise aren't optimized. So that's where those recommendations for 150 minutes of aerobic and 30 minutes 2 to 3 times a week of strength training. For fluid depletion and dehydration, recommending again, continue to carry that water bottle, keep it with you, 8 to 12 glasses of water per day or cups. And then there's still some lack of clarity about long-term pancreatic, hepatic, and other organ effects on these populations. So it's continuing to be studied. And then routine screening. So they're going to keep an eye on the patient for all of these different markers. And then for weight and BMI, a patient's weight and body mass should be documented every time they're seen in clinic. And they should be also monitoring body composition. And then labs drawn for kidney function and liver function. And then cardiovascular health, regular monitoring of blood pressure and the lipid profiles is recommended. Here is an infographic for how we educate people to mitigate constipation in the event that it comes about. So maintaining good fiber and water and plenty of body movements are great ways to help prevent this from happening. But if it does, the way you sit on the toilet does matter. So the image on the right here shows the feet propped up on a squatty potty, which is a lovely tool to help place the knees above the pelvis, which puts your pelvic floor in a nice open position and elongated position to help for better stool passage. You could certainly put whatever you want under your feet. It could be yoga blocks, it could be old Legos, whatever you got. You can just prop them under those feet, but the essence of this is knees above the pelvis. And then from there, in pelvic health therapy, we teach how to use intra-abdominal mechanics to ease the stool. And the three cues that I like to give are the three Bs. So it is, and you can try this as you're sitting there if you want to. So belly big. So expand your belly as if you were trying to pretend you have a basketball in there. Belly big, belly hard. So tighten it slightly and blow. What you should feel is a drop of pressure happen in your pelvic floor. You're not doing a Valsalva, so you're not bearing down. You're not straining the pelvic floor. You're just creating a nice suction of air coming down and through. So three Bs, belly big, belly hard, below, in that position. The other thing is we advise patients not to loiter on the toilet. So no more than 5 minutes. If you're sitting there and nothing's happening, wipe because that can help stimulate the intestines. There's a reflex there for that, but go ahead and wipe, pull your pants back up, head out of the bathroom and move around a little bit more. You can do some stretches, some marching in place, some cat and camel type exercises. But what we don't want is for you to sit there and strain, especially if you're not using a squatty potty and getting compression of the nerves behind your leg there. So get up, move around, come back at a later time. Menopause. So certainly perimenopause and menopause are associated with hormonal changes, can certainly also affect people with endometriosis, and it has been a population that is looked at with regards to how these drugs are used. The Menopause Society has released the following statements. They note that lifestyle intervention is recommended for all individuals, but lifestyle intervention alone, so that would speak to the physical activity and the nutrition side, is typically not sufficient to achieve the weight loss that a lot of people want and need due to compensatory biological mechanisms that increase the appetite and compromise metabolism. And we're going to talk about PCOS next, but menopause is one of those where the changes in the hormones can really work against someone who's doing all the exercise and eating all the right things, and they are in a metabolic situation that is really hard to overcome. So the guidelines from the Menopause Society are recommending additional interventions. So obesity medications, bariatric surgery, which is not what we're talking about today, but it is one of their recommendations for those that are meeting the eligible criteria. But also looking at long-term weight loss maintenance and reducing the risk of obesity-related complications with use of those medications. So effects of estrogen decline in perimenopause are significant. But a couple of them include altered metabolism, and lower estrogen also reduces insulin sensitivity and can increase visceral fat deposition. So it's your body starting to place fat in places where maybe it didn't used to before. And then hepatic glucose production rises and skeletal muscle becomes less efficient at glucose uptake. So the result of that is a higher fasting glucose, higher insulin levels, more fat storage, and difficulty losing it. Super unfair. But GLP-1s improve insulin sensitivity and reduce hepatic glucose output. So the enhanced glucose dependent insulin secretion helps with stabilizing postprandial glucose, so your glucose levels right after you eat. And it helps with the delayed gastric emptying and smoothing the glucose absorption. So that's where GLP-1s can be assistive with that estrogen decline. Regarding estrogen decline and appetite, estrogen decline increases appetite and leptin resistance. GLP-1 restores that satiety signaling, that signal to the brain that says, you are full, stop eating. That signal gets blunted when we are in a low estrogen state. Declining estrogen and progesterone disrupt appetite hormones as well. So the brain becomes less responsive to those cues, and that can lead to overeating and cravings. And the GLP-1s act directly on the brainstem, as we talked about. So it is working direct to reduce the appetite and the cravings and enhance the hormone signaling that says you are full and improving food control. And as I mentioned, some of that inner dialogue of the brain, and then the emotional eating patterns as well. So because the other thing that the swinging estrogen does is result in some mood shifts. And for some people, they soothe by eating things that are tasty, which is totally understandable, but certainly does not help them when they are looking to try to lose weight. Looking now at the inflammatory and cardiovascular effects in that low estrogen state, estrogen exerts anti-inflammatory and vasoprotective effects, and postmenopause systemic inflammation rises often. So endothelial function declines, but GLP-1s have anti-inflammatory and vascular benefits. So this is now another population that we're seeing this in. So a reduction in inflammatory cytokines and oxidative stress, that is just overall good for you. And then an improvement in endothelial function and arterial stiffness, so decreasing cardiovascular event risks, and then lower blood pressure and improved lipid profile, so helping with the cholesterol. Looking now at GLP-1s and PCOS. There's some emerging data on that. So PCOS is polycystic ovarian syndrome. It's a reproductive endocrine syndrome classified by hyperandrogenism, chronic anovulation, and polycystic ovaries. So it can be problematic for fertility and have a lot of side effects in and of itself. Some of the sequelae of this, roughly 50% of them have insulin resistance and obesity and or overweight. And then type 2 diabetes is also prevalent. So comes along with hypertension, so high blood pressure, hyperlipidemia. Those are the most common metabolic abnormalities, and it affects roughly a third of women with PCOS. And weight loss is regarded as the first line treatment. So then it becomes a bit of a slap in the face because now this population has a metabolic syndrome, and they're being told, if you just lose weight, it will help your symptoms. And then they fall into this cycle where they are struggling. So weight loss is regarded as the first line treatment because it can potentially improve PCOS parameters, including the androgen levels, menstrual cyclicity, and lipid and glucose metabolism. So it's helpful to overcome those. There was a fairly recent systematic review on GLP-1s on the metabolic and endocrine parameters on those people that have PCOS. And what they found was that the GLP-1 receptor effectively reduced body weight and improved some of the endocrine and metabolic parameters of polycystic ovarian syndrome. And a combined treatment with the GLP-1 receptor agonist and metformin had significant effects on weight loss and favorable results on endocrine and metabolic parameters. They do know that further research is needed to determine the long-term safety of the combined therapy of those two medications in those with polycystic ovary syndrome and obesity. Microdosing, still relatively new. A lot of people doing it in different ways. It is a titration of the dose under the advisory of the physician. And the alteration of the dose is usually taking smaller amounts. In some cases, patients may accidentally do it. And in some cases, they're trying to draw out what they have. There was a period of time where we went through a shortage and a lot of people trialed microdosing on their own, and they had some pretty interesting results. And that's where I think a lot of notice came to what would happen if they were just taking smaller doses. In some cases, it could be driven by the patient because the cost of the medication, and they're wanting to stretch out those doses. In a lot of cases, it is due to the side effects. So they're wanting to recognize the benefits, but they are really struggling with the nausea, or perhaps they're vomiting, or feeling some of the effects of the fatigue. Availability limitations, I do think we have pushed past this. There's now different options available. And then maintenance therapy. Some people reach the point that they are wanting to be at. It's a healthy state for them, and they just want to maintain. So they're taking lower doses to maintain that weight after they've reached their goal. And then others are just needing a more personalized approach. So the lower dose might be effective in avoiding those side effects. And that's where I read a great quote that was from a physician, and they said, "This is what we do with any other medication. I don't know why we're calling this microdosing. This is just practicing medicine. We're just changing the dose of the patient." So I think the more colloquial term is microdosing, but it is truly just the physician managing the patient to find the dose that's appropriate for them in that particular stage of their life. So the current evidence for this is still developing. It's recommended that the patient works with their prescribing provider to find the right dose for them. And there's that quote, "That's not microdosing, that's just the art of practicing medicine." So key take-home points. There's evidence for the efficacy of GLP-1s in weight loss and type 2 diabetes. It's really important to still maintain water intake, nutrition, and physical activity. And there's emerging evidence on the support for it for PCOS and menopause due to metabolic changes in these conditions. And I think what we're seeing reflected on those effects on inflammation is probably the effects that a lot of people with endometriosis are feeling when they are taking it, and they are just feeling better, and they are feeling more like themselves, or maybe a version of themselves that they've never felt before, depending on how long they've been living with the disease. So that's what I've got for y'all tonight. I know it's been a long day with these
Excellent,
back-to-back.
excellent. So, if you ever want to know what Sally and Andrea do when they don't know what to do with themselves, it's read GLP-1 research. I love the talk. Do you want to can you stop your share for a second?
Yeah.
Yeah. I think one of the things that's interesting, we had Dr. Vidali on a different webinar who talked about in adenomyosis, for example, the histamine response at the adenomyosis lesion, and how he believes that, like at that cellular level, the inflammation that the mast cell reaction is causing can be mitigated a little bit with GLP-1. It was fascinating when he was, yes, yeah.
Love that.
We see that. And then we also see that when we talk about PCOS, like it's for many an anovulatory experience, right? There is no ovulation because the way the sugar interacts with the ovary, it in some ways prevents ovulation. So, by the way, GLP-1s make amazing eggs, like incredible eggs, like our IVF friends, like who put even patients like who maybe are like not exactly a string of pearls configuration with PCOS, but they can't figure out like, and it's not, they've treated the endometriosis and like really incredible, very strong fighting eggs, the PCOS, the GLP-1s. And the tirzepatide a little bit better than the semaglutide, but patients tend to have more side effects from one or the other. Yeah. Yeah.
Love
So,
that.
yeah. Somebody asked a question about chronic diarrhea and GLP-1. I actually see chronic diarrhea more often than constipation, but I wonder, so I know the answer, but I wonder what your answer might be for that. Aside
I
from talk
use
to your doctor, because don't forget, neither Amanda or I can prescribe.
Yeah,
Yeah.
exactly. I would be recommending a follow-up conversation. A couple of things that I might recommend are trying psyllium husk thrown in with the yogurt. It helps to make the stool more formed, which makes it easier to manage. And then I would also look at the other things being ingested and just be sure that we're not over consuming caffeine, some of the spicier foods and things that tend to be a little bit irritating, but had colectomy as well, which I do see prevalently with the chronic diarrhea in that patient population. So from a nutritional standpoint, I would recommend trying the psyllium husk into whatever you can stir it. So yogurt, oatmeal, mashed potatoes, just to help thicken the stool a little bit. And then seeing if there's some bulking agents that could be recommended from the physician. What do you think, Sally?
My original prescriber, the person who originally prescribed me the GLP-1, has ulcerative colitis himself. So he's a big fan of the GLP-1, but again, what he does is he kept people on that lower dose longer because in those cases your goal is not necessarily weight loss. Your goal is the anti-inflammatory effects. So I see that a lot. Also the other side of the coin is will GLP-1 make something like a SIBO worse because there's more fermenting in the gut? What's your opinion? I have my own opinion on that, but what's your opinion on that?
Oh, gosh, it's so tough. Gut microbiome might be the next frontier of looking at it. Um, I would be interested to know what the rest of the flora was looking like. But yeah, I don't know.
Yeah, well, I think that is the answer. We don't know because we don't exactly know that SIBO is like if anyone had normal gut microbiome, whatever that is, would motility matter? Like we don't have that research doesn't exist yet, but I have patients that say I have SIBO and I'm already burping from that. I'm not willing to try it, which to each their own, but I also feel like you're already burping. What do you care? You're just burping a little more. That's I think so we have in the clinic there's been some issues with people having some have SIBO gets worse. Sometimes SIBO is inflammatory and it gets better. Sometimes the inflammation reduces enough so that the probiotic can actually help because the doctors go take a probiotic. You take 50 probiotics, they never have, like sometimes it helps enough. Yeah.
I was almost thinking it would be protective, the GLP-1, because of the anti-inflammatory effects of it, that they might experience like a calming effect of
Yeah,
it.
I've seen it both ways. I'll also say I couldn't, for 15 years, I couldn't tolerate dairy. And now, although I shouldn't eat it like it's my living, I can tolerate like a little bit of dairy once a week because I think the inflammation is very managed by the GLP-1. Yeah. What do you see like? There's a lot of like I hate it. I hate the resistance, but there's a lot of resistance. Like I see practitioners, particularly PTs more than anything, go, well, my patients should just try diet and exercise. Like I think that's like saying like in a chronic depressive state should just like try to watch a happy video on YouTube. I
I
mean,
agree.
yeah.
I agree wholeheartedly. And there's now, I mean, I've now spoken with so many physical therapists that experience it at perimenopause or just various stages of their life that was like, I am living the same life. I am a physical therapist. I am still running and I am gaining weight and this is not making any sense. And they went on them and recognized the effects of them. I and I think that's where the guidelines for physical activity and nutrition remain. And I think it's also really unfair that with these metabolic syndromes, like especially with PCOS, to say you're in this metabolic process, lose weight. And they're like, how? Like, how many minutes of my day would you like me to be out there exercising? I have a full-time job, you know. So
Also,
just
don't forget, most people with endos sometimes just it's not in their capacity to exercise.
yeah, exactly. They're not feeling well.
I thought like so another thing, I don't know if you've had people experience this, is like so many doctors tell like heavier, I'm a little heavier, so heavier people, although I'm 40 pounds lighter, but a little like anything that's wrong with me, they tell you to lose weight, right? There's a lot of fat shaming, especially in pelvic pain. Like, the nerve in my leg hurts. Oh, you should lose weight, whatever. So when I finally started taking the GLP-1, I remember the question was, oh, if I get it compounded, is it going to show up in my chart? Because I don't want a doctor to know. I don't want them to know because then for sure they're going to say, oh, just stay on your GLP-1 and lose weight. Do you have pelvic pain patients after the years of gaslighting who experience the same thing?
Absolutely. And I've always attributed it to the anti-inflammatory processes. But yeah, absolutely.
I just didn't want any of the like MDs to know, because that's it, Oh, see, we were right. We told her to lose weight, but it's really more than that. Now, the other thing with the compound, do you find like that's when I find microdosing really, really helpful because it keeps that dose steady. Do you find that patients experience that?
I do, and I feel like they like it very much. They just feel better. And some of the pens, I'm forgetting which one, but they're coming with the small clicks. So it's like click, 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 click.
Yeah. Do you want to tell people the difference between compound and not compound? I don't know if you like, I could do it, but you could do it too.
Go, no, you go ahead, right ahead.
So, like with the GLP-1s, of course, there are drugs that are prescribed. They're Eli Lilly, whatever. You go to the pharmacy, you go to pharmacy, Costco, CVS, and in the beginning, they were like $1,000, right? Because even though it says you have to be over like 30 BMI, you could be 35 BMI, and insurance basic, maybe they're paying 250 of it. You still have to pick up the rest of it. Like it was a big nightmare. And then if you lose any weight, you're still not qualifying. You lose it right away. And so there emerged an entire industry in custom compounding these drugs. And there was a lot of controversy about that. And sometimes the workaround on the custom compound is they're compounding B6 or magnesium, but then they're putting the GLP-1 in it. So the custom compound for many is much, much, much more affordable, easier accessible, typically run by services that don't give you a hard time about getting it, and that also have a lot of support related to the GLP-1. So the real drug comes in like a pen, although Dr. Vidali tells me there's drops now too. I don't know very much about the drops. The drops supposedly have less of a chance of causing neuropathy, but I don't have any neuropathy anyway, so I don't care. So, and then there is one that's in a bottle and you can draw out a unit, a unit, a unit. Most people that are using it for pain or inflammation, they want that unit like every day, every other day. So they do the compound, but the compound expires like that compound, that bottle's done a few months. Even before the bottle is empty, the compound I feel doesn't last as long.
Uh,
So, yeah, I don't know if you have people experience that. Do you have people?
I think sometimes, yeah. Is
Yeah.
there?
Um, and I don't know anything about the pills. So you said something incredibly interesting to me.
Mm.
You said that when in menopause or with this shift, the hepatic metabolism is less efficient at glucose uptake in skeletal muscle. How does that affect? So I think for a population with endometriosis who's incredibly fatigued, how do you think something like that could affect this population?
That's a really great question. And the estrogen can be pretty wonky
Yeah.
in the endometriosis population. So I mean, I'm afraid to speak without the data, but I
Right.
do think
We
that
have to admit the data isn't out there, but
yeah.
that's the first time I've heard that about the skeletal muscle and the glucose uptake.
Um, I mean, the other population that I thought of when I read that was Crohn's and ulcerative colitis
Ah,
because they are a like highly fatigable, not just sleepy fatigable, musculoskeletal fatigued population. And they also have the declining lean muscle mass too. Now, certainly, I'm not suggesting that population should just be placed on the GLP-1s, but depending on their status. Interesting.
yeah. And our EDS crowd as well. They're highly physically fatigable. I mean, I can say, like not that this was the most important thing in my life, but I went from being like kind of a semi-mediocre fat tennis player to really being extremely fast and like we're leveled. I went up 2 levels in less than a year. And like even though I won a national championship before, like the difference between playing like a tournament where you're playing maybe 2 rounds is incredible. So like I don't get tired. I play 4 or 5 hours a day. So I think it's amazing to hear that there is this shift with the glucose into the muscles. Like I never did, people told me I would lose so much muscle, but I had a friend who was a nutritionist and she like really stayed on me about the protein and I put on a lot of muscle. And I think that's the deficiency before prevented any muscle from being put on.
Yeah, that's incredible.
Yeah, I don't see like when my patients go on it, I don't see any muscle wasting because
Yeah.
I don't see that. I see that in what I call the Upper East Side crowd, like the people who are like on it just to be on it, but I don't see it. Um, in our population, I see people who are like they want to be out there, they want to, and this was a enabler. So, what other do we have any other questions?
Let's see. I was looking through the questions box here. We went over diarrhea, risk of developing insulin resistance with long-term use of GLP-1. Data is not out yet. With it being a relatively new prescribed drug class, only, I don't think we're even to the 10-year mark. So that one I can't speak to. And then Mamta had to jump
The
off.
problem is that um, for those that don't go, like if you're insulin resistant to begin with, how are you going to tell if the drug caused insulin
Yes.
resistance? Like,
Precisely, which is exactly what the drug was originally prescribed for.
right. I'll also say, like, egg problem aside, I had PCOS, and then like the minute you go into and I also went into menopause at 42 because of negligent surgery. But the minute you go into menopause, that PCOS is metabolic syndrome. So I might have gotten away with being keto and this and that, and then like that's it. Your estrogen is gone until you're. That's a whole different webinar on the on supplementation. That we did that last year at the summit. That's on the YouTube. We have an estrogen webinar, but that's a different conversation. So we have a question. Um, do you think GLP-1, do you think semaglutide or tirzepatide is more effective? Let's break it down. We'll start with that.
Yeah, because I think because she's asking about the naltrexone too, which is
Yeah.
interesting. So I've gotten better patient response with tirzepatides as a general class, both for the weight gain and the way that they feel. And I think it's the mind chatter and then like the energy levels and those kinds of things. So I would say anecdotally, I've had more patients feeling better on the tirzepatides. Gosh, and then
So
comparing it.
tirzepatide more expensive, just putting that out there,
Yeah.
which is why I never tried that one. Now, low dose naltrexone is a totally different class of
Yeah.
medication. So it's not if or instead of or choose one or or we shouldn't be in that situation because they do totally different things. I'm on both. I'm trying to think of the 10 patients I know on GLP-1s are also on both. And it's not one or the other, I think. And norepinephrine, I don't know how that, I would have to defer to Dr. Vidali on that conversation.
Yeah, and I do know for some patients they will be prescribed the naltrexone as a weight loss solution because of the psychosocial, like the mind chatter.
Right, but with it's a known sort of Hashimoto's cocktail to do low dose naltrexone combined with Wellbutrin specifically for Hashimoto thyroiditis inflammation. It's a very
Mhm.
specific cocktail that they use for that. And I am on that for the Hashimoto's to maintain the Hashimoto's numbers, but the GLP-1 I'm on for something else. So I don't think it's one or the other. Do you see
Hmm.
more side effects between tirzepatide and semaglutide?
Hmm.
Different from person to person, no?
I think, yeah, I don't know that I don't know that I've seen one more than the other.
Yeah, I think usually what I see is patient comes in and they're prescribed one and they can't take it, so the doctor prescribes the other one. That's why I like the compound because we are sensitive people in the pelvic pain and endometriosis world, and you can stay on like 1 unit or 2 units for a very long time. Yeah, more, more than somebody who has to click that pen up. So, yeah. Um, have you seen any research on C-reactive protein and GLP-1?
No, have
That would
you?
be good. No, we should ask the big guy that though. That's a good one for Dr. Vidali. He's coming next
Yeah.
week. Not for GLP-1, but that's a good one to ask him. I'm writing it down. So come back next week, anonymous attendee. Um, well, also there is a new GLP-1 coming down the pike that is much stronger than what's out there. Like we're gonna think these drugs are a joke. So there's a question about metformin versus GLP-1. I have very strong feelings about that. What are your feelings about that, Amanda?
I think it's dependent on the diagnosis. And there's side effects with the metformin too. I think
That's a good question.
anecdotally patients are doing better on the GLP-1s, but I don't know. What do you think?
Okay, so I think I was metabolic syndrome, and I'm in the category where I needed both. And also the long-term effects of metformin and aging are amazing. So, especially on a low dose metformin. So, I am on both, but my patients, particularly younger patients, have horrible stomach problems from the metformin. I mean, I talk to patients, I turn on the Zoom and they're like crying from how bad the metformin stomach aches can be.
Yeah.
So I see both. So if you take the GLP-1 correctly, there's very low risk to hypoglycemia. So there's no point, harm in sort of mixing them if they're prescribed properly. Yeah, but properly, that's the problem. Yes. Wait, there is one more question. Well, so I do like to say I alluded to it, and you said the same thing. GLP-1 treats one thing, and thyroid medication treats another thing. You're rarely fat only because your thyroid is out of whack, right? So like maybe you're tired because of that. Or that I have that with my patients all the time. Like the Hashimoto's people who have endometriosis surgery, who are so fatigued going into surgery, they're going to come out of surgery fatigued because we're only treating the endo, we're not treating the Hashimoto's. So, like, we can't forgo good medical care just because one drug is not going to treat everything. Yeah, yeah, yeah. So, all right, round it up. Now even more. We were very popular tonight.
Oh,
Uh,
they're coming in
uh,
different places.
they're coming in different places. Um, we talked about chronic diarrhea already. What I don't know very much about the I don't even know how to say it. The retatrutide, the new drug that's coming out. That's a Dr. Vidali question. He's on
Yeah.
board with that.
Oh, good.
Yes. That's that
Yeah,
again, favorite thing, favorite pastime of Dr. Vidali is reading GLP-1 research because it's so connected to that immune system.
absolutely.
Yeah. But he like could walk around an airport and be like, "Have you tried it yet?" Yeah, he's like, so we're like that. So I think so here's where we are, Endo Summit crowd. We are just beginning the conversation about GLP-1 in our community, and certainly in the menopause community, in the PCOS community. We're just, this is like sort of cracking the surface a little bit. So we didn't get to every concept and question that you have. But it's just the start. So Amanda, we end every Endo Summit Live almost the same way. What do you uh what do you look forward to the most every year about the Endo Summit?
Oh, I mimic Dr. the physician previous to us, the learning. I always learn. I mean, especially on day one when all of the surgeons are presenting their new data and sharing the new things that they've tried. I just look forward to that every year.
Yeah, so the Endometriosis Summit is coming up March 27th through 29th in Orlando and virtually online from anywhere in the world. There are portions of the Endo Summit that are sold out already. In particular, our POTS lab is sold out in person, which is 55 people in an in-person PT lab is pretty impressive.
That's
But
amazing.
for the rest of the summit, if you are looking to purchase tickets, www.theendometriosissummit.com. And don't worry, we have arranged some surprised guests so no one misses out, right,
That's
Amanda?
right. That's exactly right.
All right. We'll see you soon. Thank you for joining us. This was amazing. Really fantastic program tonight.
Oh, thank you so much. I always love being here.
Yeah. Thank you. Take care.
Thank you. Have a good night.